Hello.
Hello and good evening, everyone. I am Dr. Ajinkya Nanavre from MCure Pharmaceuticals. I welcome everyone to the No Thrombosis workshop in acute ischemic stroke. In the previous workshops, we had a very unique and interesting case discussions, and we are looking forward to have a fruitful discussion today as well. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. And it is my honor to introduce our faculty for today. So let me share my screen, sir. So is my screen visible to everyone? Yes. Problem. So first, I welcome Dr. Subhash Kaul sir. Sir is a senior consultant and a stroke specialist at KIMS Foundation and Research Center, Sikandrabad. Sir has been faculty for 27 years at Nizam Institute of Medical Sciences, Hyderabad, and former professor and head of Department of Neurology and also dean at NIMS. Sir has more than 120 publications in the national and international journals. Sir has been principal and co-investigator of several national and international projects, including the largest center, Hyderabad Stroke Registry, funded by the ICMR. Sir has been awarded by the State Teacher Award by Telangana government in 2017. Sir has been past president of AP Neuroscientist Association, Indian Stroke Association, and Indian Academy of Neurology. Welcome, Dr. Kaul, sir.
Thank you.
Then I welcome our first moderator for tonight, Dr. Meenakshi Sundaram, sir. Sir is a senior consultant neurologist at Apollo Hospitals, Madurai. Sir has more than 20 years of experience in neurology and has presented many papers at various prestigious national and international forums. Sir has received Best Research Paper Award at 10th Annual Conference of Indian Academy of Neurology. Sir has been principal investigator for many international trials. Sir has been editor of the South Asian edition of the book Practical Neurology and also contributed to many books on neurology. Welcome, Dr. Meenakshi Sundaram, sir.
Thank you, sir. Thank you.
Then I welcome our second moderator for tonight, Dr. Tarun Nagpal, sir. Sir is director at Aditya Super Speciality Hospital and Trauma Center, Jabalpur. Sir has interest in cerebrovascular disorders and started the stroke thrombolysis program in MP in 2009. He also has, to his credit, the first plasma exchange for Hashimoto's encephalopathy in India. Sir has interest in sleep disorders and conducting sleep studies for neurological conditions in a level 1 sleep lab setup. He has been associate editor for Annals of the Indian Academy of Neurology for 2 years. Dr. Nagpal sir, welcome to No Thrombosis Workshop. Then I welcome our first speaker for tonight, Dr. Sudhir Chakravarti Dasaraju sir. Sir is consultant interventional neurologist at Manipal Super Speciality Hospital, Vijayawada. He has more than 11 publications in multiple journals. He also has membership of Indian Academy of Neurology, Society of Neurovascular Interventions, Indian Stroke Associations. He has expertise in performing various diagnostic and therapeutic neurointerventional procedures like digital subtraction angiography, intrasinus thrombolysis, intraarterial thrombolysis, and mechanical thrombectomy. Welcome, sir.
Thank you. Good evening, everyone.
Then I welcome our second speaker for tonight, Dr. Jay Shah. Sir is consultant neurologist at Previs Neurodent, Jamnagar. Sir has multiple publications in various journals and experience in acute stroke thrombolysis, deep brain stimulation in Parkinson's disease, Botox therapy, electrophysiology department, and managing medically refractory epilepsy. Sir has special interest in management of stroke, epilepsy, migraine, movement disorders, and neuroimmunological disorders. Welcome to No Thrombosis Workshop, sir. And with this, now I would like to hand over this session to our course director, Dr. Subhash Kaul, sir, for his opening comments and context setting. Dr. Kaul, sir, over to you, sir.
Yeah, thank you very much. I think it's my great pleasure to again set the context for today's meeting. You know, month after month, we discuss very interesting cases. As you know, the highlight of our program is that it deals with the real-time cases, individual cases. And many times in individual cases, there are dilemmas, there are issues which guidelines don't answer. And we have had wonderful cases. We have got wonderful doctors participating in this. And we have learned, all of us have learned so much from these cases, which we have not even learned from our books by their personal experience. So with that, I request my dear friends and the moderators, both moderators I welcome, and I would request Dr. Meenakshi to begin the proceedings. Dr. Meenakshi.
Thank you very much for making me part of this program, sir, giving me this honor. Thank you very much, Dr. Tarun Nagpal, sir. I think please, we are waiting to learn from the two speakers today, sir. Waiting for that, sir. Dr. Tarun, sir.
Thanks a lot. I think it should be a very interesting session. And as Dr. Kaul said, that each case is different, and doing the things beyond the guidelines comes with practical experience. So today's two speakers, the two eminent speakers, will present the cases, and then we can have the discussion. So we can start with the.
Yes, Dr. Sudhir sir, you can start presenting your case, sir.
Yeah, good evening, everyone. Thank you each and everyone for giving me this opportunity. I know it's a difficult task speaking before eminent people like you, but I'll try to do whatever I can. I'll try to do my best. With this, I'll start my presentation. Is it visible?
Yes, yes. Your screen is visible.
Okay, I'm going through my case.
Okay.
So this is the case of about a 50-year-old gentleman. He's a diabetic and a hypertensive. He is a college lecturer by profession. He was on regular medications for his diabetes, hypertension, statins, and he was on clopidogrel at the prescription of a cardiologist. That was only given as a primary prophylaxis. His coronary angiogram was normal otherwise. He presented with sudden onset weakness of the right arm and inability to speak for about 2.5 hour duration. His arm weakness partially improved over 1 hour duration by the time he presented to the hospital. Clinical examination, he had Broca's aphasia, partial UMN palsy, and mild right arm weakness, NIHSS score of around 8. So the initial investigation, that was in an MRI. An MRI showed areas of diffusion restriction in the left frontal cortex, predominantly in the inferior frontal gyrus. This is the image of the flare. You can see on the flare, there is a diffusion and flare mismatch. And along with the flare mismatch, you can see the hyperintense MCA vessels in the Cillian fissure. So on this MRI, we have a hyperintense MCA branches in the Cillian fissure, apart from a diffusion and flare mismatch with an infarct in the left frontal region. This area more or less corresponds to the Broca's area. So along with that, we did an MRI angiogram. An MRI angiogram showed the occlusion in the distal MCA in the M2 divisions. Both the superior and inferior divisions were not visualized. There is an occlusion in the Sylvian segment of the left MCA. And the other tricky part of the story, he had a subdural SDH. That was a subacute subdural hematoma. So when we inquired into his history, he gave a history of a head injury that occurred about 3 months back during a motor vehicular accident. He was not evaluated for that same because he wasn't quite symptomatic for that. So this is the main crux of the story. What would you do in an acute ischemic stroke that has a concurrent post-traumatic subacute subdural hematoma? Do we proceed with IV thrombolysis? So when we look at the inclusion and exclusion criteria, whenever we do IV thrombolysis, a significant head injury within the previous 3 months is a contraindication. So there were some trials that were conducted that were omitting the conventional criteria. People have tried giving IV thrombolytics in the subgroup of people who are not fitting into the conventional criteria. There were certain case reports, but there was no concrete evidence that somebody did a post-traumatic SDH giving IV thrombolytics. All the data that I could get was in a prior history of intracranial hemorrhage, but few studies have omitted their intracranial hemorrhage. And in some studies, there was an increase in mortality who had intracranial hemorrhage and post-traumatic SDH or subarachnoid hemorrhage. Only in a chronic subdural hematoma, the people have tried given thrombolytic therapy, but what are we facing now is a subacute SDH. That's not a chronic SDH. So even in some other review of literature in the intracerebral hemorrhage, they have done safely given IV thrombolytics without no significant difference in the mortality rates. But again, post-traumatic was excluded from this study. and off-label use of IV thrombolytics in acute stroke. Only one case of head trauma, but not an SDH, and that was a remote symptomatic bleed. And there was another study, a multi-smart study. In this, the only absolute exclusion criteria was an acute intraparenchymal hematoma. That was the contributor of this the patient symptoms. And all the relative exclusion criteria were included, even IV thrombolysis in this particular study, even in patients with head trauma. And they found that in patients with a head injury, we can safely give IV thrombolysis. Even some studies have tried using IV thrombolytics as an off-label use. People have done successfully without much complications. Prior head trauma or a surgery, they did not report excessive bleeding complications. So coming back to this case, we did not have any definite consensus on a patient with acute ischemic stroke and a subacute subdural hematoma. All the studies were in intracerebral hemorrhage. Most of them were deep-seated hypertensive bleeds, very few cases of head trauma, and one report of increasing bleeding complications in those with a subdural hematoma. So each patient would need an individualized treatment plan. This patient in particular is a lecturer by profession, and speech deficit would be particularly troublesome to carry on his profession. All the pros and cons explained to the family members. If at all the SDH worsens, he might need an additional surgical procedure in the form of a burr hole or a craniotomy, or maybe an embolization procedure endovascularly. Family members were reluctant for IV thrombolysis. So we gave them the option of endovascular treatment. So we shifted him to cath lab for a mechanical thrombectomy in view of a medium vessel occlusion. The occlusion was the level of M2. So people have tried during direct thrombectomy without doing IV thrombolytic when there is a, and there are some exclusion criteria for IV thrombolysis. The results were equally good. And even in the NEJM study, that was a non-inferiority trial comparing thrombectomy with and without IV thrombolysis. So we shifted this patient to cath lab. And when we did the DSA, it was a little surprise. Both the M2 divisions were clearly visible, and only the branch that was occluded is the precentral branch. That was a branch from the superior division. These are the divisions of MCA and the branches of it. Only the precentral division that supplies the frontal cortex was occluded. But the MR angio, initially what we saw, there was an occlusion in both the divisions. So why there is a discrepancy between the MR angio and the DSA? So there is an algorithm to define this. What if we see a change in the level of occlusion at the baseline and the follow-up vascular imaging? Three possibilities can be seen. Either there is a complete recanalization, or if there is a more distal occlusion, if the occlusion has changed from a proximal location to a distal level of occlusion, as like in our case, we call it a thrombus migration. What if there is no change and we find an additional distal artery occlusion, like there is an occlusion at the proximal as well as at the distal, we call it a thrombus fragmentation. And in our case, the point of interest is a thrombus migration. Thrombus migration has been reported in about 1/3 of the cases of MCA occlusions, more common with cardioembolic and following IV thrombolytic therapy, but is also reported to occur even spontaneously. And thrombus migration is associated with better functional outcome. Back to our case. So this is what we have seen, acute ischemic stroke with a branch occlusion. No IV thrombolysis was given. There is no point of doing any mechanical thrombectomy in this. So what are we going to do now? So again, we thought of doing an intraarterial thrombolysis. What is the current evidence of intraarterial thrombolysis? It is used for distal occlusions, as like in our case, adjunct or rescue therapy after a mechanical thrombectomy. In comparison with intravenous thrombolysis, there is a better visualization, better efficacy. There is a requirement of lower dose of thrombolytic agents, and you can get a better recanalization rate. The dosage is not clearly defined, but the highest dose that we can give with tenecteplase is about 24 mg. Alteplase is up to 30 mg. There is one paper that showed good results comparing intraarterial thrombolytic with mechanical thrombectomy as well. And the results with intraarterial tenecteplase and mechanical thrombectomy as compared to the recanalization rate were comparable, as good as a mechanical thrombectomy. So in our case, we did a intraarterial injection. This is the DSA run that is showing the culprit occlusion, the precentral vessel. So we negotiated a microcatheter into the occluded vessel. And this procedure was done under conscious sedation without any general anesthesia. So we engaged the culprit vessel and we injected an ectoplase into it, and we could get a good recanalization. The vessel would be completely. So this is after giving an intraarterial tenecteplase, we could get a complete recanalization. This is the follow-up CT done at 24 hours. This is the area of infarct, the subdural hematoma, the subacute component. Following that, we started him on dual antiplatelets, keeping a close watch on that. This is his clinical video done about 7 days later. So he could get back to his professional work as a teacher. This is 3-month follow-up CT. There is a slight reduction in the SDH, even on dual antiplatelet therapy, and the infarct remained as much the same. So endovascular therapy has been a paradigm shift in the management of acute ischemic stroke, especially when we have some exclusion criteria. Concurrent SDH should not deter in acute ischemic stroke management. With the current armamentarium, we can effectively treat them. Individualized treatment plan weighing the severity of the stroke with IV thrombolysis, IAT, or mechanical thrombectomy. If the subdural hematoma is not a significant one, we can even try giving IV thrombolysis. If at all there is a worsening of SDH, that can be safely handled. SDH is an extra-axial pathology, so treating an intra-arterial ischemic stroke gives a priority over SDH. Thank you.
Dr. Meenakshi, can you take it on? Thank you very much for your very good case, learning experience. Meenakshi Sundaram.
Sir, that's a really extraordinary presentation, sir. I was really zapped when I listened. That's a beautiful way. And congratulations, Dr. Sudhir. You have taken it extraordinarily. I can say this really. Now, comments are as follows. If the patient had agreed for IV thrombolysis, personally, I think I would have hesitated. I would like to hear the views of Kaul sir and Dr. Nagpal sir also, because the hematoma appears quite sizable. And very importantly, sometimes the MRI, we may not be able to really get how acute it is because we are more trained towards looking at this in CT scans. So when I saw the CT scan, subsequently, it appears subacute. It's still at least white there. It is not the hypodensity which you are seeing there. I would not have been so brave to have given IV thrombolysis in that case. That's one thing. And I'll give you the second comment after sir teaches us about it. Would you have given IV thrombolysis?
No,
here,
I would not have given IV thrombolysis because you see, guideline is something and individual experience is something. So I would only talk about guidelines. As our speaker has told, there might have been cases who have been given IV thrombolysis and they did not extend. After all, having a subdural hematoma does not mean that it is actively bleeding at this time. It only means that there is a residual blood. And that definitely does not mean that if you give IV thrombolysis, it will extend. It may not, because now the blood is resolving. It is said that within 2 weeks of the trauma, the bleeding stops usually. And that's why you are allowed to give aspirin after 2 weeks. So it may, but if you go to guidelines, guidelines don't allow you. Guidelines don't allow you to give thrombolysis in head trauma within 3 weeks. Because suppose if there's a bleed and all that thing, then it's a problem. And there is a bleed because it's a soft brain. Guidelines don't allow you to give IV thrombolysis in any intracranial bleed. It is not intracerebral alone. It's intracranial, which includes subdural, subarachnoid. As long as you see blood there, guidelines don't allow. The only exception which guidelines make is that if there is a very remote hypertensive ICH, remote, which means many years ago, 10 years ago, or if there's a remote head injury. So I also would not have given, but that does not mean that an individual doctor cannot give. If you take the consent and if you, tell, but on my own. But mechanical, I would have gone straight away if it was a case. Unfortunately, this was not a case. And short of mechanical, I think intra-arterial makes sense because you are doing it very locally and you are hoping that. So I would really appreciate what he has done. I think this was the best thing to do under these circumstances, and it has really succeeded. Hats off, congratulations. Everybody doesn't have this kind of infrastructure. Everybody doesn't have this kind of people and initiative to take it forward. So once again, another learning case. Great. Thank you.
Thank you, sir.
Akmal, sir.
Yeah, no, thank you. I think this is one of those cases which we are talking about, where practical experience counts and guidelines are not everything. But I would agree that do no harm should always be there. So in this case, if I see anything white on CT, right, and I would not thrombolize the patient. That is there. Anything hypertension, wherever the blood is intracranially, I would not thrombolize. Giving an antiplatelet in a situation where the patient had MI and a stent and you are worried about things like that, stent thrombosis, it's okay. So you can use an antiplatelet in those situations. But seeing the blood, I will not do an IV thrombolysis. You did the right thing of going in. I had just one query. When you saw that when the MRA and the DSA, there was a difference, right? And you thought that there was a thrombus migration. Was the patient also improving once the thrombus had migrated? You said that there was some deficit earlier, and the patient, when you saw the patient, he was improving. Was the deficit improving between the MRA and when you went in for the intervention?
No, sir. Even before he reached the hospital, he noted that his grip started improving and weakness started improving. The only deficit at the time of examination is mild loss of dexterity in the right hand, along with aphasia. It's completely aphasic.
Right. So the MRA and the DSA, although there is a difference in the vessel, how the vessel looked, probably the clinical condition of the patient did not change. Is that right?
From the MRA to no, sir. From the MRA to the DSA, there is no change.
There is no change in the clinical condition of the patient.
Yeah.
Now so that is something which becomes tricky. So you expected that the clinical condition would also be improving since the patient had got some sort of spontaneous recanalization. But I think you've done a remarkable job, and the patient has also benefited.
Yes, sir. I don't have an explanation why there was no clinical treatment. That was what happened.
Sir, one comment about the recanalization which you mentioned. See, the paper which you showed was in 2011, which compared intra-arterial with mechanical thrombectomy. Those were the times, in fact, I believe we had only those first generation stent, this one, Penumbra system. Probably the comparison today would be quite different, I think, because as an interventionalist, you would be telling us much better than this.
Yeah, definitely, sir. Definitely. I just wanted to I noted that was the only one decent paper on intra-arterial tenecteplase usage. And that was a randomized study when comparing mechanical thrombectomy, and that was 10 years ago. Today, even people are changing distal vessel occlusion just with aspiration devices with smaller stent retrievers. So no, I don't think nowadays only people use intra-arterial only after as a rescue. After doing a thrombectomy, and if you don't find a good recanalization, we give a small bolus dose. Some people use tenecteplase, some people use tirofiban. That is only as much of current evidence of intra-arterial usage of thrombolytic agents, only as a standby agent and not as a primary treatment.
In those days when we were doing this intra-arterial before the advent of this mechanical thrombectomy, we were told to use 1/3 of the systemic dose. So this was one of the so-called, within quotes, unofficial guidelines.
Yeah.
Did that hold true for you also, sir? 1/3 of the systemic dose.
Yes, sir. I just if I had to use Altiplase, usually we'll give 5 mg. We'll take a control run if is there a good recanalization. Again a 5 mg bolus and then check the recanalization. With tenecteplase, we give 2 mg boluses. So it took me around 6 mg. Because we see visualization of recanalization, we stop it when we get a good result. We just don't keep on pushing the thrombolytic agent without any rule. We just wait for the.
Tell me one thing, Dr. Sudeep, that finally, which vessel did you? It was a branch of the MCU,
Yes,
not
sir.
But if I remember in the last guidelines, I'm not sure about the latest guidelines, but in the last guideline, if there was a branch occlusion of MCA, means beyond M2, they were recommending, it's a weak recommendation, but they were recommending to give intra-arterial. That was the only situation where intra-arterial could be used, even as per the guidelines, even though it was a weak.
I don't know.
I
Sir.
don't know what is the latest guideline.
I don't know.
Now
Sir.
it's totally out. Now it is out totally.
Yeah, nobody uses that, sir. Even with the distal M3 occlusion, people are using those aspiration devices, smaller caliber ones.
Okay. Because now, as Meenakshi said, now we have got better device. That was before the device.
Definitely, we have better devices.
Great.
There was this choice trial also, this chemo optimization. Like you give what you have done there. Isn't correct, sir?
Yeah, correct.
So that was a really great, brave move, I should say. And the results are really fabulous, really fabulous. The worrisome thing about subdural than any other hemorrhage is that, as sir was saying, it keeps on oozing. The oozing nature, is quite unpredictable. That's why, we would have really been hesitant to give any IV TPA in this patient. Really, IV tenecteplase TPA. Any other hemorrhages are still fine. At least we will know they'll only go for resolving course. The subdural hematomas can be really cranky. Really. Wouldn't have even afford for IV thrombolysis.
But for this kind of at this level of arterial block, there we don't have any mechanical device available. Do we have, Sudhir?
Yes, sir.
For
We have, there's a device from the BALT, Catch Mini.
But it was not available to you.
No, I don't have that.
Because we would have been safer with that.
That's the expensive one, sir. That costs.
Okay. Right.
As of now, the recommendation stays as per the Dawn, Diffuse, all of them is only up to, they have done only up to M1. And M2 is just allowed, correct, sir?
Yes.
M1 is what is established, M2 is allowed.
Allowed.
Beyond M2 would be tough thing to do, really. We in our hospital don't touch beyond M2. M2, M1, sometimes M2.
This is good. I
It
think
was
we can move to the next case.
Yes. It was very, very excellent case presentation, sir. I must congratulate Dr. Sudhir. It has been appreciated by our audience also in comment section. So we will be moving towards our next case. So I will be presenting for Dr. Jay Shah's case. So I think he has joined from his mobile. So I will be presenting for him. Dr. Jay Shah, can you hear me? Sir, I think you are on mute, sir. Yes.
Am I audible?
Yes. I am sharing your case, sir.
Okay. Good evening, sir. Good evening, everyone. Good evening, all seniors. I'm Dr. Jayesa. I'm practicing in Jamnagar, Gujarat. It's a peripheral town, so unfortunately, we don't have cath lab facility. I have to send the patient to Rajkot. It's a 1 hour journey. So in all cases, IV thrombolysis or as a bridging, it's very important to us. So I'm presenting a small and good case. Can you share the slide?
Yes, I'm sharing.
Yeah. It's a 59-year gentleman, right-handed individual, and artist by profession. He's a piano vadak. It's very important to know his profession as far as the stroke is concerned. He's basically a known case of hypertension, type 2 DM, and he had coronary artery disease since last 7 years, and on irregular treatment with uncontrolled hypertension and diabetic. There was no addiction except some tobacco chewing occasionally. Next, please. Next slide, please.
Yes. There is some issue. Yes.
He had presented with history of sudden onset of weakness of the right upper limb in the form of difficulty in gripping the objects and some deviation of the face towards the left with some slurring of the speech of some basically had Broca's aphasia, mild. Onset of weakness around 900 hours in the morning, presented to us around within 2 hours, around 11 o'clock in the morning, with all the symptoms. On initial assessment on vitals, his pulse is 109. It was irregular, misbeats was there. Blood pressure was 136 by 94. Random blood sugar was 278. His ECG is suggestive of atrial fibrillations. Urgent CT was done within a few minutes, as in-house CTs we have. So its normal aspect score was 10. His NIHSS score was on 4 only. As far as the clinical scenario was concerned, only some right facial paresis, right faciolabial fold was this, and motor right upper limb weakness power means score-wise it was 2, because he had some hand weakness also there, and language-wise only mild weakness was there. So given the score was 1, so the NIHSS score was 4. Next slide. So CT was normal. So after CT, as far as the guidelines concerned, means FDA approved RTPA was there. I'm using that. But as far as the pocket friendly and the patient is not affording for RTPA, I'm used the tenecteplase 16 milligram 8 ml. As far as the weight is 80.7 kg. His post thrombolysis NIHSS was good. It was improved, and only some speech difficulty was there. This was the next slide. This was the MRI. As we can see, the diffusion restriction with the some MEDICI values, and the angio was suggestive of left MC occlusion below means ahead of M1 with the carotid angio was normal. So post thrombolysis, next slide please. Post thrombolysis is, we can see, is very good opening of the M1. We don't require means send for the mechanical thrombectomy as far as the clinical as well as angio was concerned. It was improved. So the only small message is the thrombolysis with a NIHSS score, but having a major clinical deficit. Sometimes we are dealing with the major deficit, or might be we are dealing with the large vessel occlusions, which affect the patient outcome and his profession. Thank you.
Yeah. Hello.
Hello.
Yeah, I think that is a good case, and the message is that we should always give probably IV TPA first, because 30% of the blocks also can open. Mechanical can open more than that. Mechanical can open up to 70%, or even more than that, 90%. But even IV thrombolysis can open. So this has happened with us also many times. And in fact, tenecteplase is thought to be better than alteplase in opening the large vessel. So I think that message is well taken. Meenakshi, over to you.
Thank you, sir. That's a great case, really, because this is what was shown in that Extend IA TNK trial, I think. These were a set of patients who were, scheduled for thrombectomy with a window of 4.5 hours. And then these patients were given initial, tenecteplase. I think it was compared with alteplase. Yeah, it was compared with alteplase, and the opening was 22% with the tenecteplase and 10% with alteplase. So much so that Bruce Campbell wrote that if you give tenecteplase, the chance of this patient being taken up for mechanical thrombectomy greatly decreases. Absolute almost 12% was noticed. So probably this is one of those cases.
Dr. Nagpal, sir?
Proceed with IV throm. Sorry, sir.
Okay. Okay, sir. I think I lost.
Even if are you able to hear me?
Yes, yes.
Yeah, even if there is a large vessel occlusive disease, we should not hesitate to give IV thrombolysis. That's a key message here. In fact, the second study which comes to my mind is the Tempo 1 data where tenecteplase in stroke with a proven occlusion in minor strokes. Like this cannot be considered exactly minor, though NIHS stroke scale is 4. You have a Broca's aphasia component sitting there. So today's criteria, though NIH is less than 5, it goes through one of those exclusions in the form of language deficits. But there also it was shown that with tenecteplase, with proven occlusion, there was opening up of the vessel. So those two trials are actually corroborative with this case. The only doubt I have with the speaker is this. Sir, you did the CT scan and then you thrombolized and then
Yeah,
you
I've
showed
done.
2 MRIs, one without opening and one with opening. What
Sir,
was that actually? I didn't get that actually.
So I've done a CT scan. On the CT scan itself, given a bolus tenecteplase. After CT, you're done. Go for the MRI.
Yeah. But that MRI, what did it show? It showed block.
Yeah, the block.
And when was the MRI repeated? The second MRI.
The second MRI repeated after 24 hours. That is a normal. There was no any the ICH or anything. Only bleed was there.
So there is one deviation in the guideline, if I may just point out. The case is extraordinary because the patient has improved clinically and you have got a vessel also opened up. But today's guidelines say that if you have an occlusion, even if the patient has improved, let us say even if the NIHS has become absolutely okay, you have to go and open up the vessel is what is actually being practiced. At least our interventionists, that is the way they practice. Without opening, I mean, you just straight away take up for patients for endovascular and try to open up the vessel. So fortunately, this opened on its own. I'd like to hear the comments of Paul sir and Nagpal sir on this count.
No, see, the today's recommendations are, and what is done in practice also, is that you give IV TPA or tenecteplase anyway, and if it's a blocked vessel, you don't repeat the MRA to check whether it has opened, or you straight away take it to endovascular. But what will happen is that many times when they are doing DSA, they find the vessel is open. In that case, they will close the procedure. They won't anyway again do the procedure. But there is no need. But the recommendation, because you waste time in that procedure to do the MRA again and all that. You just after giving IVT, take to DSA. And yeah, I agree with you. That is the current practice. I think Dr. Nagpal may give his comment.
Yeah, I think it depends upon the place where you are practicing.
Yeah.
See, he's in a place at Jamnagar, and I can identify because I also come from Jabalpur, where the intervention facilities are not available. And if the patient is improving, it is very difficult to convince that patient to go undergo a DSA further. So it is, I think what he has done in his situation is perfectly justified.
Okay.
So now what we would have done here is that we thrombolize whatever if there is no bleed, you find out a reason to thrombolize. Go for thrombolysis. It is the other way around. Don't look at the contraindication unless something is glaring at you. You see blood there. And we thrombolize the patient. Now, whether these patients should go for the bridge, if available, all of these is a matter of contention. Now, since this patient has done very well, even with IV thrombolysis, it makes a point that not every patient requires a mechanical thrombectomy.
Correct.
So I think
my
it's
question,
my
question to Dr. Shah is, when you gave IV TPA,
Yes,
in
sir.
how much time you noticed that there was clinical improvement of his aphasia and of his brachial paralysis? In how
Sir, for
much time you noticed? Was it immediate on the table, or did it take 24 hours? Or was it?
Sir, basically some patients like this, some having
No,
a
in this
cardioembolic.
patient, I'm asking, in this patient. In this patient, in how
Sir,
much
yeah.
time he made in this patient, in how
Improve
much time he made
within
clinical
1 hour.
improvement?
These patients improve within 1 hour, 45 minutes to 1 hour. Because I think it may be a cardioembolic stroke, which very soft, which thrombolize very well. So these patients improve within 45 minutes to 1 hour.
So there was, anyway, he could not afford mechanical thrombectomy and all.
Yes, sir. Because he doesn't having the money to spend of even RTPA. It's 3 times costlier than the tenecteplase.
Yes.
So he's not affording. So I think it's better to do something rather than do.
That is true.
Do
That
nothing.
is true. That is completely well taken. It's
is definitely, we must give IV TPA. And if the patient is affordable, and if you are in a setting, as Dr. Nagpal says, if the patient has not completely improved, take him to an endovascular lab. But then if the
True.
patient cannot afford, and if you are in a remote area, then definitely this is the maximum you can do there, and also very good.
True, sir.
And in fact, the maximum recovery which happens in the TPA, alteplase, and same is true about tenecteplase also, is to be seen at 24 hours, not immediately. Thank you.
True,
Sir, without prejudice, I have a question.
Yes,
If
sir.
you can. Yeah, without prejudice to the company, right?
Yeah.
So what is your current thinking? How do you rate tenecteplase versus Actiplase?
You're asking me, or you're
Yeah,
asking
yes,
the company?
no. I am asking not. I am not asking the company. I know the company's answer.
No,
So
but
I
I think Meenakshi wants to answer that question, so it's better that I will divert it to Meenakshi because he has
I
raised
can
his
answer
finger.
that, sir.
Meenakshi, I
Allowed,
saw
I
your
can
finger.
answer that. See, if you look at that, almost all are the same. Even the meta-analysis which Dr. Kameshwar Prasad group they published, they're almost the same. Sir has published that. But the point is that if you look at only one parameter, as Kalsar was just pointing out, see, if you look at the long-term outcomes, they may be comparable. But the very acute outcome, if you look at that, the dramatic improvement they talk about, 4-point improvement in a night stroke scale, that is one thing which has been seen more often with tenecteplase than alteplase. That's one point which they have really scored in data-wise. The long-term outcomes may be comparable. I will leave it to the others to decide upon that. Is that correct, sir?
Yeah, no, you see, if the issue is that if you look at the studies individually, one by one, in no study, tenecteplase has been found to be inferior, because I have studied this. Whether it's a study from Scotland, whether it's a study from New Zealand, whether it's a study from Australia, whether it's a study from India, there is not a single study I am aware, or whether it's a study from Nortest from Norway, there is not a single study where it has been found to be inferior. It may not have been found to be superior, although in extent intra-arterial they have found little superiority, but otherwise it is non-inferior. So that means it is as good. But still it gets a weaker recommendation. And why? If you see American guidelines, it is recommended now, but its recommendation is weaker than that of alteplase. The reason for that is that for giving strong recommendations, they need more studies and more follow-up. In the more studies, more, because it's a new drug, so therefore its recommendation is weak. If you take European guidelines, if you take American guidelines, all guidelines are recommended, but they have given it a lower place. And the reason for that is not because the trials are shown, because there are less trials, and because the trials have not been, the time period is only last 2-3 years. Whereas with alteplase, otherwise from the survey of literature, they look equal.
One practical advice, Dr. Jayasha sir. One thing which we have learned, I have to tell you. See, you specifically said that the patient was not able to afford. But when this happens to better as this patient, actually, ideally within guidelines, we must offer endovascular. And if we are finding that it is open, we are going to come out. But let the decision be taken by the family, even if the patient has improved. And we have seen that when there is a major vessel occlusive disease, they can deteriorate. At that time, one uncle will crop up, or one cousin brother's son will come, who would be, coming and trying to make some noise and saying, why you did not do it? And our own colleagues, sometimes they let us down. Oh, you should have come early. So document it in the case file that this patient did not afford. I offered the chance for them to go for endovascular and they didn't take it. Write it in native language, preferably even if the family is not signing it. You documented at that same ink which you documented the previous and at the same time put the time.
Sir, that was done and I have taken the consent also.
Yeah. Okay, then fine. Thank you. Just express it to us also, because that's very, it has happened. That later on they will say, we never said we cannot afford, no?
True,
That
sir.
will come
True.
back immediately strongly at us when the patient
True, sir.
doesn't do well. Here they wouldn't do it because they did very well. But the patient who doesn't do well, they will really come back.
True, sir.
And they will, because they would say that even after spending 30,000 rupees which the doctor gobbled up, the patient did not improve and did not even answer anything.
Very
That
true.
will be the answer for them.
Yeah.
But that's a really great case. Really, opening of the point which you have highlighted for us is that A major vessel gets opened up when you give IV thrombolysis, especially with tenecteplase, obviating the need for mechanical intervention. That was the learning point we had from your case.
Meenakshi, I tell you, I have had this because I'm older than Jay. I'm older than you also. That's my only
Very well
claim
said.
to fame, that I'm old man. But this has similar stories I remember now. I had once a patient, I was traveling actually, and during travel, somebody called me from the hospital that there is a so-and-so patient, there's a complete block, and what to do. I said, call the interventionalist. And we had only one interventionist. Most of the hospitals either have no interventionist or there's only one who's very much in demand. And they said this interventionist is not available. Why? Because he has gone to attend an intervention conference. So, see, that shows the effect of conferences on patient care. He said, sir, he has gone to Bombay. He's not available because he has gone to attend an intervention conference. And intervention is something which you cannot do by telemedicine. IV TPA you can do, IV tenecteplase you can do. But intervention you have to hold. I said, okay. I was very, very, unhappy. I said, okay, what to do? I was also traveling. I said, okay, give thrombolytic agent, we'll see. And by next day when I went to hospital, I found he was completely all right. And in fact, I show that case often in my conference. He had completely recanalized. And similarly, another time also I had the same experience. And then I looked at the literature. Actually, if you look at the literature, 30% of these large vessels, which can involve the major vessel and which can involve the branches also. Usually branches get, but sometimes even the M1 also depends on the composition of the clot, and how the clot composition varies. If it is a ICAD clot, it will not dissolve. Or ICAD, even mechanical, is a very difficult thing because it is embedded in that. But if it is a cardioembolic clot or a clot of unknown source, they can many times this thrombolytic IV thrombosis. So therefore, it's a good thing. And even in these intervention studies also, they have shown that many times when they go to I have also seen this. Many times when they go to intervention, they think that many times the IV itself has done the good job. So it's a very good message, and it reinforces that concept. And in this, as you rightly said, tenecteplase has been thought to be better, the trials wise. That in fact there was a hope. That hope could not be fulfilled when the tenecteplase company was promoting tenecteplase. When it was promoting, in that this was also one of the promotional points that it will replace mechanical thrombectomy. But that dream could not be fulfilled. It could not replace it. They were so excited that it is because there was some data in Extend trial, where they had shown, even before Extend, they had shown that there was some tendency recanalize the large artery. But then subsequently we learned that there may be a little advantage, but it cannot really replace mechanism.
I think the biggest advantage of yeah, please. The biggest, no, it's okay. The biggest advantage which we found of tenecteplase is ease of administration.
Yeah,
so that is one thing which is see, you are not there at the bedside and you just give a bolus and it's gone. So you don't have to document the time when it is given, not the time when it started and when it ended, and whether the infusion was slow and dissolution and this. So all this is gone. So that is the biggest advantage.
That 1 hour of tension is not there.
Yeah.
Go and give it this way or that way.
Yeah. So that's
an advantage during Corona time.
Yes.
Really, we did not have to go near the patient. Just give it and come off. Sir, one thing, sir, before the advent of tenecteplase, when the recanalization rates were actually being looked at, only when alteplase was available, there was percentages in one of the data that spontaneous recanalization 24.1%. With the IV alteplase, it was 47%. With the intra-arterial alone, it was 63%. Intra-arterial as a bridge to intravenous was only 67%. That is only, it added only 4% in that data. And the mechanical with penumbral device was 83%. So this was the original. So probably it was a spontaneous recanalization with 24%. Sir, I had also an incident like that, sir. We had a patient who came beyond the IV thrombolytic window referred to us for only mechanical thrombectomy and with a dense deficit. And we did for the first time our angiography in our hospital. I think it was CT or MR angiogram. I'm not remembering right now, sir. We did that angiogram and we found that there was a major vessel occlusive disease. And we immediately took the patient for intervention. Inside, we went there. The angiography time to the needle and going inside would not have been more than 10-15 minutes. That is all. Only shaving and take up, that is all. Everything was ready. We used the code stroke and we went inside. And when we went inside, the vessel was completely open, sir. The argument was that why the vessel opened up. Now, the argument was that it could have been spontaneous. But then it was 8 hours or so for the travel to reach us. We are opening at 8 hours. What it did not open in 8 hours, what happened in that 15 minutes? So our interventional radiologist, Dr. John, said, sir, we give heparin to flush whether it opened up. So I want to know really the veracity of this statement. Does heparin flush really open vessels? Does it really happen, sir?
No, by anecdotal experiences, it happens. Depends upon how, because mechanism-wise, heparin basically stops the propagation of the clot. It is not a thrombolytic. It propagation, but suppose if there's a small clot, it prevents its propagation. It is possible. It's not guaranteed, but it's possible. We have heparin is a hated word. Heparin, if you talk in favor of heparin, you are uneducated. But there are enough incidences, anecdotes, some of which I have myself experienced, where heparin has been shown to really do wonders.
This
Possible.
was a surprise for us.
Possible.
Real surprise for us.
Yeah, it is surprising
15 minutes
because
it changed.
because flushing is used in a very small doses. So it is not like a therapeutic dose of going a big bolus of heparin. So
That's true.
it's very difficult to say comment.
Why did it open, sir, in your opinion? This was really surprising for just 15 minutes difference. And the argument I was saying that spontaneous. Why it did not happen for 8 hours suddenly? Then he gave the final answer. We touched it, sir. He said the patient had magic touch. Beyond that, we couldn't say anything. Good results, and we are happy. That is all.
No, yeah. But you are right. You are right that it is not a thrombolytic agent, mechanically. Or maybe it was just by chance that at that time it had to, clot can spontaneously also get resolved or thrombolized. Maybe heparin gave it just that little push. It was already on its way to resolution, and then heparin gave it a little push. It's also possible. Yeah.
So did the patient improve at that time?
Yes, sir, improved. The payment of the lab, not immediately, I would say, but rapid improvement was there for the patient. Very rapid improvement subsequently. And they were very thankful to us. They thought that only with the cath lab we have improved. So we had to tell them that we have not given anything there. And they said, no, modesty. That's all. We are also happy. They are happy, sir. That's all. But the truth is that nothing we did.
Good.
Two great cases, sir, really.
So sometimes the opposite also happens. I remember a case where, as sir said, the intervention is not available. So once the relatives come to know that the intervention is required and intervention is not available, that's the bigger problem. So now the protocol is first find out whether it is available or not, and then give the option.
Correct.
True, sir. True.
Yeah, they get fixes. They get obsessed with something which is not available. They will blame you for it.
Yes. So it happens.
The same things that when our interventional radiologist goes for the conference, probably they are attending together, sir, with your interventionist. It really creates trouble. But in Madurai, what we do is that, sir, what they do is that at least one is available in the city. There are 3 in our city. So they see to that at least one is available in the city. The two other guys go and tell each other and go. So that way we have an advantage. Otherwise, it is real trouble.
So I think both cases were very great. We have experience and we have seen these kinds of cases before. They only revalidate our impressions. But there are a lot of people who are watching this webinar and who are new in thrombolysis. I think for them it's a great lesson that they should never give up in any situation. Even if they are in the remote area, they should not think it's a large artery block, therefore I have to send. No, just do what is available at the time. Give IV. That's a message for them. And similarly, that endovascular, the first case, that also is very good, where you have, when we think that intra-arterial thrombolysis is out, it still has a place in. It just depends on how much initiative we are able to take and how much risk we are able to take for the benefit of it. Sometimes you have to do that. That extra inch matters. So great cases. Congratulations, everybody.
So, Kaul sir, I want to know one thing from you.
Yes, sir.
Since you have so much of experience on this. So what do you think is a contraindication in your eyes at present for IV thrombolysis, apart from the frank bleed which we see? So a patient has been on low, double antiplatelet, he has been on low molecular weight heparin. So you do think those are contraindications?
They are not contraindications.
You go ahead.
I think they are not. I think I would like to know your opinion also, and Meenakshi others' opinion also. But I think major contraindication is a brain hemorrhage. But let me tell you one thing. This is just out of personal. I have seen some patients where a minor sulcal bleed was missed and they were thrombolized, and bleeding did not increase in them. But I would not recommend that to do it. But in spite of that, because that was after TPA was given and patient improved also. Then we picked up there was a minor bleed, so nobody talked about it. But hemorrhage is definitely absolute contraindication. This is one. Second is if you have had a major surgery. Major surgery means something like a coronary artery bypass, something like an abdominal surgery. In the preceding 2 weeks, I would be hesitant. But minor surgery is not at all a problem. Means ophthalmic surgery, even ENT surgery, something which is superficial and that's not a concern. But major surgery would be another contraindication. And third is that, because I have burnt my fingers, is this stroke, ischemic stroke in the last 1 month at least. Although it is written 3 months as per the guidelines. But major surgery in the last 1 month, ischemic stroke in the last 1 month is a contraindication because, again, that area is little ischemic, little soft, and you may bleed. Other than these three, or trauma in the last 1 month. Other than these three, I cannot think of any. I can't think. Can you think of any other contraindication? Everything is allowed now. Even guidelines is allowed.
Yeah.
Acute anterior myocardial infarction in the preceding 2 weeks.
But not an absolute contraindication. Not an absolute contraindication. They are allowing it. I have checked the recent guidelines. It used to be 2 years back an absolute contraindication. But if you see 2021 guidelines, they are saying that there is a net benefit in that also. That risk of cardiac rupture and risk of pericardial thing has been thought to be very little, and net benefit is there. That also is not most of them have become now only absolute contraindications are, I'll tell you, because I have reviewed this so many times. One is APTT, if it is much beyond 40, that's absolute contraindication. If your INR is more than 1.7 and the patient is on oral anticoagulants, that's absolute contraindication. If you have had a major surgery, maybe, or if you have a brain hemorrhage. Most of the times you will find a reason to give.
Therapeutic heparin, sir?
Huh? Therapeutic heparin also is a contraindication.
And what about the NOACs?
NOACs, everybody knows. NOACs is that if it is given less than 48 hours, then you should not thrombolize unless you have given them idrusuzumab for dabigatran.
So we have taken at those surgeries which are compressible site. We give those which are recent and non-compressible, just avoid. So
What
if
was
they will-
your experience in surgery?
in surgery, so there have been not many cases, but those which have been, so internal surgeries, so someone got a gallbladder operated and there is a thick inside, we don't do it. Hernia, fine, we'll do it. So that way. So things which are more superficial, ENT, we will do it, compressible.
Oh yes, oh yes,
And
oh
so,
yes.
so
oh,
things
yes.
like that. So compressible versus non-compressible.
Yeah, I have my experience is that initially we used to be worried even about gum bleeding. But as time went on and we learned, now I have given in many patients following cataract surgery and nothing has happened. ENT surgery, nothing has happened. No, not even bleed also. And of course, one is diabetic retinopathy, in which there is bleed also, in which it is allowed. Now, guidelines also say that you can go ahead and give. So today, before we think it's a contraindication, we should check the literature. Is it really a contraindication? Because again, the patient may catch our collar next. That's why you didn't give me. Because there are hardly any contraindications. Only these 3-4 are. Most of them, at least you have to give option to the patient.
I think better to give the option to the patient and tell them that there's a risk, higher risk. Guidelines are not very clear, but if you say we'll do, and we have given earlier, and if they agree, better to give it.
Absolutely, I completely agree. So another bugbear of this is this contraindication. The bugbear is this mild deficit, and we have had discussion on this before. And particularly this mild deficit fellow is a VIP. You see, if the mild deficit would happen in a normal, ordinary person like us, then it is not a bugbear. Then we listen. No, okay, it's not. But he is generally either MLA or your director's brother or a Supreme Court judge's cousin, and he comes with a mild pronator drift. Now you don't know should you give or not, because if you are damned if you give, you are damned if you don't give. So that has been an issue with me, what to do. But if you see, guidelines are clearly saying, guidelines I'm talking, that if you think it is disabling stroke, that even if it is mild, you give it. And I think Meenakshi and me had a discussion that we think that every neurological deficit is potentially disabling, even if it's a pure. So we can document that thing and then give it. Unless patient himself refuses, which is a blessing if the patient refuses himself. That I find very stressful. When a patient has a mild deficit and to give or not to give.
But if you see, those mild deficits also bleed very rarely. So it's okay to give, I think, in those situations.
That's
the
true.
ones, yeah. So the chances of bleed are also lesser. The small
You see,
strokes,
that is what we thought, and that is what Pooja Khatri thought. Pooja Khatri is she's the eminent stroke specialist at this time in the world. We should all be proud of her. She's a Punjabi from Chennai, basically. Her sister is still living in Chennai. And when Pooja Khatri comes, she goes to Chennai first, because her family is in Chennai, even though they are Punjabis. So she's a #1 stroke specialist in the world. We are thinking of inviting her next year to India. So she led this. She was a big proponent, any number of papers by her, that why are we excluding mild strokes from thrombolysis? This is wrong. There is no data to substantiate. This NINDS trial according to NINDS trial, mild strokes are excluded. And what is mild strokes? Anything less than 4. And it so happens that there was no data actually. There was no data. In fact, it was done purely for safety of the patient. But if you thrash the data and go into it, what they have seen is that those mild strokes who were thrombolyzed, they did very well actually in NINDS data. So therefore she said, she came with a hypothesis, we should thrombolize mild study. And they did a study which Meenakshi often likes. That's called PRISM study. Now in the PRISM study, they took very mild strokes and non-disabling strokes, mild strokes. And what happened is that they could not get enough cases over the course of time. They could not get enough cases, so therefore there was some funding problem. So they could get only some 1/3 or some proportion of cases what was supposed to be done, and they did an interim analysis of those cases. And in those cases, they found that those mild strokes which were thrombolyzed, there was little more bleed, which unfortunately crossed that statistical line. It was. So then they said that there is some 3% bleed compared to those. Based on that, then And then she herself was very embarrassed. But the study was imperfect, study was not complete. And but because of that, they say that mild strokes, but only good thing they have written is that mild strokes which are non-disabling need not be thrombolized. But that the million-dollar question is, who will decide? Now they have said that non-disabling means which does not interfere in his day-to-day activity of life, and they have defined those also. What are his day-to-day activities of life? Like wearing his clothes, brushing teeth, shaving. And if these are not interfere, then it is thought to be it's a non-disabling stroke. And so, but this remains a little bit of a mild pronated drift on left side. He may still be able to button, but he may think it's disabling for him. So to make the long story short, whenever a patient has any deficit, I give him the option. And the other thing is, which nobody talks, that is the whole tragedy of stroke. We think of the deficit at this moment. We think it is mild disabling at this moment, but after half an hour, it may become disabling. At this time, it is non-disabling. After half an hour, after all, what is the aim of thrombolysis? You are dissolving the clot. So you are preventing further progression. So he may be having non-disabling at this time, at 9 o'clock and 8 minutes. But what about 9:15? By the time he may become disabling. So therefore, I think I would thrombolize. I would explore the maximum chance of thrombolizing each and every person, and I would try hard to see what is the contraindication. If there's a contraindication, then obviously. What are your comments, sir? I'm more interested in learning from you. What is your experience?
You're asking me?
Yeah.
Yeah. So, sir, my comment is that I find a way to thrombolize, as I said before, to find out how I can thrombolize unless there's a glaring contraindication, which we already discussed. So I would thrombolize a mild stroke, and we have been doing it, and with good results, and rarely ever bleed. I don't remember having a bleed sort of in which I embarrassed myself and to do a non-disabling stroke, to do a whether disabling or a non-disabling mild stroke. Except if there would have been a mild sensory deficit or something which cannot be documented objectively, I would thrombolize.
I think Meenakshi has a story to tell about the sensory deficit, which he didn't thrombolize, and the patient is still blaming him.
Is it?
Meenakshi, would you tell us that story?
Same thing, sir. We didn't traumatize the person saying that it is only numbness. The patient has not spared me, sir. More than 10 years, he has haunted me that you should have numbness to understand this. So any deficit is disabling for the patient. So that's a great learning I had with that patient. Because he asked, what do you think you have got numbness? If you have numbness, do you know what it means really? For you, it is nothing. For me, it really means a lot of. And I came to you in right time.
So he has got a valid point, but you have a defense. You could have said that there was a chance of bleed, So I did not want to take the chance of that bleed, which is there. So seeing the risk benefit. See, I think it is if things don't go the way we plan, and sometimes the expectations are not met, then these things keep on coming sometimes, but they can be handled. But that is in general, most of the patients would accept that. Had this patient bled, then he would have blamed you more, So even though the chances are very less.
At least, the patient said, weakness, at least I can do physiotherapy. What physiotherapy for sensory loss, you tell me. So I was zapped really. There were two papers also at that time. This was several years ago. Two papers. One was the TGT paper. I think it came in 2005. These were patients who were considered by the treating physician as too good to treat. And I think 1/3 of them could not be discharged home. Was from one of the Western data that these patients had to go to halfway home or some nursing institutions whom were thought that too good to treat were not good enough to be discharged. And there was another analysis, I think it was in 2011, of patients called RIS. These were rapidly improving stroke symptoms. And when you look at it, the paper itself was titled that not a happy ending for people who had rapidly improved stroke symptoms, RIS. So these two were great guidelines at that time. Again, Dr. Pooja Khatri madam's data was actually not giving us enough, will to say that, unfortunately. We were also looking at the data very closely, whether it will really help us. The conclusion was that there was a trend towards improvement within quotes and then within brackets, not statistically significant. That's how they had actually ended that paper.
Yeah, correct. So I think thank you very much. I think we hand over to our
Yes, sir.
our MQR team, Ajinkya.
Yes, sir. Hello. It was a wonderful, wonderful workshop, sir, with so much of information for our audience. And I would like to thank all the faculty members for taking some time out from your busy schedules on this evening of the weekend. And thank you, Jai sir, Dr. Sudhir sir, for presenting those interesting cases, sir. And also thank you, Dr. Kaul sir, Dr. Meenakshi sir, Dr. Nagpal sir, for your expert comments and great practical insights. And we would really like to work under your guidance for many such future programs. So with this short note, we will close this session and thank you everyone again. Have a happy weekend and good night.
Thank you. Namaste.
Thank you. Good
Thank you,
night.
sir. Thank you very
Thank
much,
Good
sir.
night. Good night.